Welcome to today's webinar, From Uncertainty to Action, How Objective Biomarkers Are Changing the Autism Diagnosis and Therapy Journey. I'm Bob Holly, Executive Editor of Behavioral Health Business, and I will be your moderator for the next hour. A special thank you to our sponsor of today's discussion, EarliTech Diagnostics. This is a really important topic, and I'm thrilled we get to host this webinar here on BHB. So big thanks to EarliTech for putting this conversation together. Now let's go ahead and meet our presenter for today. Cheryl Klaiman is the Director of Clinical Research Operations for Marcus Autism Center. She's also a professor at Emory University School of Medicine. Dr. Klaiman has over 25 years in autism research and diagnosis. She leads a team conducting clinical evaluations and FDA-regulated trials focused on early identification, a certified ADOS-2 trainer and expert in eye tracking biomarkers. Dr. Klaiman helps clinicians improve diagnostic accuracy, reduce delays, and initiate therapy sooner. We all know how critical that is. Her work bridges research and real-world practice, empowering professionals with the tools that they need to support earlier decisions and better outcomes for children and families navigating the autism diagnosis journey. Cheryl, Dr. Klaiman, it's so great to be here with you today. I'm really eager to learn from you. I know our attendees are as well. So I think with that, I'll step back. I'll be back toward the end of the webinar for some Q&A, but take it away, please.
Awesome. Thank you so much for that introduction, Bob. And I'm really excited to be here today to be able to present to you and talk to you guys a little bit about one of the biggest barriers that we have in the care of children and families affected by autism. And really what that is that gap between when concerns first arise, whether those are parental first concerns, pediatrician first concerns, grandparent first concerns, whoever might have those first concerns, and when we're able to get a child through the diagnostic part of their journey. And so that gap is really wide, way too long, way bigger than what it should be. Parents are sitting in a lot of angst. And so what we're going to do today is talk about this prevalence data, show how what we're currently doing creates these delays, which really can be avoidable, and what we can do to really help families on this journey and set the stage for why a more objective approach can really be a game changer in this landscape. And so by the end of hopefully this talk, you guys are going to see exactly where families and clinicians are losing precious time, why closing that gap is imperative, and then what we can do about it. So those are the kind of big goals for this chat. And so to start, we're just going to go through just a little bit of the prevalence rates and kind of highlight where the problem is essentially. And so the most recent CDC prevalence data gave the number at 1 in 31. So that's 3.2% of the US population. And this was data that looked at 8-year-olds. And so in all 8-year-olds, so think of any second or third grade classroom, thereabouts, approximately one child in every single one of those classrooms is going to be affected by autism. We do also know that parents, pediatricians, whatever it might be, start to become concerned before the age of 2. Okay, so 90% of parents are concerned by the time their child is 2 years of age. And yet the average age of diagnosis in the United States right now is about 4 years. Though those prevalence rates have been going up, so the rates of autism have been rising over the course of the last few decades, the average age of diagnosis has only moved by a couple of months. And what we're also finding in the latest data is that there's increased prevalence rates in specific ethnic and racial groups. So Black children, American Indian, Alaska Native kids, and Asian Pacific Islanders. So those rates have been going up, likely because we're doing a better job of getting all kids in for assessments. But where the burden has been lying is that the increase has been seen in those groups. The rates of intellectual disability and other delays is also heightened in those groups. And really what we found by a lot of our research is the reason for those discrepancies, that disparity in care, is because there's later ages of diagnosis and lower access to intervention. And so these are all avoidable things that we can be making a difference in. The other kind of demographic data is that boys are diagnosed still about 4 times more than girls are. And is this something that's still being researched is this a gender difference in the autism spectrum disorder, or we're just not as good at identifying girls? And there's still a lot to be said about that, a lot to be learned about that. And so in the Next slide, what I'm going to take you through a little bit is this odyssey that parents go through. So the American Academy of Pediatrics at AAP recommends specific autism screenings at 18 and 24 months of age. And again, so we're doing these screenings. Now these screenings are tagged to payment for those well child visits. So most kids going through their well child checkups are getting these screenings. And yet the average age of diagnosis, or that median age of diagnosis, is still at about 4 years of age. Okay, there's lots and lots of reasons for that I'm happy to answer questions on as well. But what really is happening is that families are then getting referred for these evaluations, but then having to wait a long time. The average time families wait in this kind of age group is about 4 to 12 months at these specialty centers. And that's actually good. Ours is a little bit longer here at the Marcus Autism Center. We're trying to find innovative ways, and I'll talk to you about one of the innovative ways we're doing that we are finding really makes a difference. And there's lots of different things that then happen. So lots of families can have lots of different pathways. So they might go to a developmental pediatrician specialist, so like a developmental behavioral pediatrician. They might go to a psychologist. They might go to a neurologist. And essentially what ends up happening is there's lots of different tools that we can be using at those time points. Sometimes families seek first opinions, second opinions, and with that, they might get all sorts of different things. All those different pathways can lead to lots of different questions that families might have, can lead to more confusion. It can lead to someone saying, yes, your child's at risk for autism, another tool saying, no, there's no increased likelihood for autism. So there could be a lot of differences in information that families might get. And what that ends up happening for families is creating increased anxiety and then also increased delays for getting access to services. And when we have that, those longer waits, again, they're increasing a parent's anxiety. They're, told that their child might not be meeting all their milestones, and yet now they can't get into a specialty center to get those answers. And what ends up happening is that they end up seeking a lot of different sources of information, right? So they might travel long distances to try and find a provider. Instead of being able to be seen at a provider that takes their insurance, they might have to go to private providers. There's just a lot of information, a lot of differences, which causes a lot of confusion for our families. And what it also means is that two different children with pretty similar patterns of behaviors might get very different answers. We've even seen it where one child was seen by one provider and a twin was seen by another provider, and they were told different information because they use these different tools. That's just really, really confusing for families and leads to increased delays even in getting services. And so these differences just, again, come about by different providers, different tools that might be used, different ways that we have of kind of assessing the strengths and vulnerabilities in all of our kids. And then what ends up happening is that when we delay diagnosis or delay any assessment, our kids are starting treatment later. They're getting intervention services later. And one thing that we know is that the brain is most plastic between birth and about 3 years of age. Okay, so we have the earlier we can identify vulnerabilities in our kids, the earlier we should be able to get them into intervention, and that should make the biggest difference and have the biggest impact on their outcome. And so if you look at this chart, what it's showing you is essentially that age that intervention starts, the greater inclusion possibilities that the child has in regular education curriculum, right? So in the later that intervention starts, the more likely they're going to need more significant individualized supports. Okay. The other thing we have in this country is a lot of access to early intervention services if the child is under the age of 3. So if our average age of diagnosis is 4 years of age, all these kids are missing that critical window for brain plasticity, but they're also missing access to a free government federally mandated support service called the Birth to 3 programs out there. Every state calls it slightly different, but these kids are not getting access to it if we're only providing them with an evaluation and diagnosis after the age of 3. So that delay, again, increases delays to services. it decreases their ability to attain services at these younger ages, which impacts their optimal outcomes. It increases family stress. It increases caregiver burden, and it also increases cost. So the older a child gets and the more specialty services they need, that increases the cost of care for that child over the course of their lifetime. Oops, sorry, wrong button. And so why does it move so slowly? And I'm an ADOS-2 trainer, as Bob mentioned. The ADOS stands for the Autism Diagnostic Observation Schedule. It's really the gold standard tool that's out there currently in use in the field. I love it. I have no problem using the tool. I think it can give us a lot of great information about a child, but there's a lot of pain points to it as well. It's a very lengthy tool to do. So if I was to do an ADOS on a child, it takes about 45 minutes to an hour or so to administer, and then another 30 minutes to score. So we're talking about an hour and a half of time to do this single measure. Again, it's going to give me a lot of great information, but the false positive rates are also pretty high because the tool itself was normed. And so the data behind it was based on people that had reached a research reliable ability to administer this tool. We don't have enough providers out there that are already doing this tool. And then these rates of the sensitivity and specificity of this tool were developed using research reliable evaluators. That's how we kind of develop these tools. There's nothing wrong with that. But when we start to implement it broader in a community that does not have the same level of experience and supervision using the tool, the rates of it overdiagnosing autism essentially goes up. We're going to see more symptoms in the tool if we don't have the same level of training. We also have other tools that can be used. The CARS is the Childhood Autism Rating Scale. The ADIR is the Autism Diagnostic Interview. So the CARS is a child-administered assessment. We're observing their behaviors and scoring it. And the ADIR is a lengthy parent interview that we're using to get information on a child's developmental history and symptomatology. And those tools are a bit older. We're waiting on some revisions of them, and their sensitivity and specificity ranges are between 64 and 94%. They were also normed on less diverse populations, and were normed on, again, a very research invested sample of participants, so parents who are wanting to bring their kids in to participate in research studies. So it's not necessarily generalizable too far and wide. And then even when these tools are administered properly, these tools and the batteries can take hours and hours of time. And so most of the time, if you're coming to a clinic to do an evaluation, so here at the Marcus Autism Center, for example, our standard evaluations, if we're thinking about what we've been doing in the past, and I'll talk to you about how we've changed some of that, take about 4 hours of time, not including an interview that's done in advance for a child and the feedback that might be done after. And so and the report that then needs to be written. And so they take 2 to 4 hours. So for every clinician, if they're seeing a child every day, they're seeing about 5 kids. We get calls here for about 60 to 70 evaluations per week. We have about 10 clinicians. So every day our wait list grows, for example. And so these tools, though very, very helpful in many, many ways, can take a long time to do, which limits, it puts a rate limiting step on how many kids we're able to evaluate, which means lots of kids are waiting, which again increases those delays, increases the age of diagnosis, and increases their ability to access care. And here at Marcus, our leader, Dr. Ami Klin, likes to say those kids that are waiting to be seen should be just as important as those kids that we're able to see. And so how can we change that balance so that we can be seeing more and more kids in our centers? The other things that happen is our tools were not necessarily normed on our current prevalence of kids that we see in our clinic. So they're not necessarily been normed on kids that don't speak English. They're not necessarily normed on kids that come from different racial or ethnic backgrounds as well. And so even then doing those tools outside of that is changing the norms of how they were developed. So we have to take that into consideration as well. And so then also when we have these tools that take this long and our prevalence of autism is increasing and our population of specialists is not really increasing and keeping pace with that, we're creating even greater delays over time rather than helping kind of get all these kids into services. Oh, I keep kicking. There we go. And so there are solutions that are coming out there, and one that I'm going to talk about a lot today is EarliPoint. And again, as I said, all our traditional assessments really depend on the evaluator's experience, right? Expertise, their ability to see a child, be with a child, and be really engaged with the child, have a high level of energy to be assessing kids. And all of our practices and insurance system changes are trying to get us to see more and more kids over time. And what we're having here is an increased level of clinician burnout as well, which then is decreasing the amount of kids that we're able to see. And there are some studies that show that expert ratings can swing more than 20% from one clinic to another. So if I see a child here and someone sees a child in Chicago or in New York or something like that, our differences can range by more than 20% on the behaviors that we're seeing. And diagnostic error also climbs about 15% with each evaluation that we have to add on to our day, right? So we get tired and we make more mistakes, is essentially what some of this is saying. Then there's also concerns with implicit bias, cultural mismatches, fatigue, everything like that will just add noise to the ability for us to objectively see and assess a child. The child hasn't changed, right? Just how we're looking at the child and who's looking at that child might change. And that variability is exactly why we need objective measurement. We want to reduce as much of that noise and that variability as possible. And so when we do have a biomarker or a more objective measurement tool, what happens, right? If we start to pair these tools with our insight, we can see some real gains in our accuracy and consistency in assessing for autism. And there was a recent study in a primary care clinic where they used a 6 biomarker eye tracking score that was put on top of that primary care physician's first impressions. Okay, so they layered that objective tool alongside the primary care provider. And what they found is that the diagnostic performance increased dramatically. And so that went to 91%, approximately 91% sensitivity and 87% specificity. And that's meaning that we're catching almost every single kid who truly has autism and saying that those that don't have autism don't need to continue on this autism diagnostic pathway, right? So it's a very sensitive and specific measure. So we're catching all those kids and being also very specific in who we're capturing. And so even standing on its own, a 10-minute passive video assessment delivers information, okay? It's giving us same-day answers because it's a 10-minute video that then gets scored behind the scenes, and you're going to see that in a few minutes. And so without that primary care provider's impressions on top of it, that sensitivity and specificity are also very high. So sensitivity of 78% and specificity of 85%. And when we look at that even more, what we're doing is we're measuring very similar things using this tool. And again, I'm going to show it to you in a second. But when we're using what a child looks at, what they attend to in their environment, those metrics explain about 75% of the variance in the tools that we typically use as clinicians to measure social disability. So if we think about that ADOS, which is a tool that measures social disability, what we're seeing is that these metrics are capturing that same underlying construct as to what we're doing. And why that's happening is that when we're looking at videos, we're attending to very social relevant information. And when you don't attend to that same information, it's giving you information about how that child is seeing their world. Okay, I'm going to show you some of the data in a second, but we've done multiple studies and we've replicated those studies. And when we replicate those studies, what it's telling you is that that data initially that we got is accurate, right? So when we replicate the studies in another like thousands of kids, so we've done this thousands and thousands of times, what we're showing is that we're able to see the same thing in the same children over time. And when we have more objective tools, those objective tools don't get tired like we do as clinicians, right? So the algorithms that it goes through when the children are watching it, it's not going to get tired from seeing 10 kids in a day like we are. And it also doesn't see the child in front of them. So it's not potentially falling for the same kind of implicit biases that we might make as clinicians. And what that does is it gives every kid an equal shot at getting early support and help. So some of the past data really shows that there has been a lot of biases in how we diagnose autism outside of our own race and ethnicity. And so these kinds of tools really help kind of level that playing field. And so what we're going to just walk through now is what this might mean for families. And so I've kind of intimated this already, but our traditional current path is a pretty subjective path. Our tools are based on subjectivity, right? We're doing something to see the behavior of the child's performance, our mood, all that can influence what we're going to see on a given day. Typically, there's multiple provider visits that are needed dependent on your state and your kind of clinic that you're working in. But we have a multiple provider visit here in order to go from getting information from the family to seeing the child to then providing feedback and getting the child access to care. Again, outcomes might shift with experience and fatigue. And if we have a child that we're scratching our head over, what this might compound is even how much longer an assessment might take, right? We might need to get more information from their daycare program or school program. We might need to see them in a different environment. We might need to follow them over time. So sometimes these cases can take even longer to come out with an evaluation result that can lead a child into treatment. When we have this tool that I'm going to, again, show you a little bit more in a minute, it's using a 10-minute test that's administered by a trained technician. And so instead of taking, an MD or a psychologist that we have a rate limiting number of, we can train a whole bunch of people in the field. We have here trained master's medical assistants. We have research assistants. We have a whole bunch of people that can be trained really easily to administer a tool such as this. And the child goes through about a 10-minute procedure where they get then a result. So a report is derived from that data. The clinician reviews it and is able to provide immediately information to a family. Sometimes we might say we want to see a child develop over time, but at least we're going to know right then and there, and we're going to be able to get the family into the next step towards intervention that might be necessary to help that child reach their optimal potentials. And so now I'm going to just show you a little bit of more what it is. But essentially, we call it EarliPoint. So it's a tool that's owned by EarlyTech. And what it's doing is it's measuring moment by moment what we're calling social visual engagement. So how a child is attending and learning from their world. This is the first tool to have an FDA-cleared breakthrough designated device. And what that means is that the FDA has looked at all of the data. They're invested in it from this breakthrough designated device, which means it's highly innovative and the data is really clear behind it. And it's this 10-minute, as I said, passive video. You see that little girl in the picture watching it. That's what the device looks like. And it's measuring what a child's looking at the rate of about one frame per 120 seconds. And as it does that, it's capturing this construct that we call social visual engagement, SVE. Oops. And so here I'm going to just take you on a little watch of this video. It's like just a couple minutes long so you can see it in action, because I think viewing it is way better than me trying to explain it out. Let's see if it works. I'm gonna go. Okay.
For children with autism, the earlier the diagnosis, the better the long-term outcome. Unfortunately, fewer than 20% of children with autism are currently identified before the age of 3. That delay in diagnosis leads directly to delayed intervention and delayed treatment. However, with the EarliPoint evaluation, we can test children between the ages of 16 and 30 months, assessing their progress on the core dimensions of autism over time. Typically, developing children viewing videos tend to focus on the same area of a scene at the same moment about 80% of the time. The looking behavior of children with ASD tends to differ, such as focusing on objects rather than faces, with important learning opportunities being missed in every social interaction. Using interpretable AI, EarliPoint assesses individual looking behavior at a rate that is imperceptible to the human eye, measuring hundreds of focal preferences per second and then comparing those data to significant attentional moments for typically developing peers. This attentional funnel provides the clinically validated reference standard that gives parents, caregivers, and providers timely, objective, and accurate information concerning potential developmental vulnerabilities, allowing for earlier identification and treatment for ASD.
Awesome. So that's just a little snapshot on what it looks like. I'm going to go into a little bit more detail on some of the data behind it. But really, that's what it is. It's a Surface Pro Plus with a webcam embedded in it, and it's put in a nice sturdy case. And so there's a calibrated monitor with an infrared camera. And again, that's operated by the clinician, and the child just has to watch. The software, as it goes through, is going to check all that data quality, and it will generate a clinician-ready report. And so, yeah, so let's just go through some of the data behind it. And so we've been doing these studies for, gosh, I don't want to date myself further than I have to, but it's been a couple decades at this point. And so we have a lot of data. When you go through to try and test accuracy, we have a discovery cohort. Okay, so we developed a model, and then we tested that cohort against a model. So that's our discovery data set. And in that discovery data set with over 700 kids, our sensitivity and specificity were both above 80. And you can see that in the first graph where the area under the curve, which is our ability to make a differential diagnosis, was about 90%, okay, or 0.9. We then want to say, does this really work? So let's take a whole new set of kids and replicate that again and compare it again to that model. And the same thing happened. So we were able to find the finding, replicate that finding. And then we say, well, this is our data, right? It's our clinicians. It's how we see autism. I told you earlier about the fact that I might see something one way and a clinician in Chicago or New York might see something a different way. So then we also went through and did what we call a multi-site pivotal study. Okay, it was a multi-site pivotal controlled trial. And we used 6 sites in this case, and they were all across the United States. So there was Emory University here. There was Rush University in Chicago, University of Cincinnati, Seattle Children's Autism Center, SARC, in Phoenix at the Southwest Autism Research and Resource Center. And I'm missing one, but there were 6 sites across the United States. And when we did that study, then again, they were trained by us on how to use stuff, but they did their own diagnostic evaluations. We found pretty much the exact same thing. So the sensitivity and specificity right around that 80% with the area under the curve at 0.9. Okay, so this is telling us in all of our diagnostic tools that we have, so the ADOS is one of them, the goal is about 80%. We're never going to have 100%. We don't have a blood test right now to assess for autism. And so it's all behavioral subjective observations. The one thing also to note is that we based our sensitivity and specificity off of clinician judgment. And when we do that, a lot of the times clinician judgment is also guided by tools like the ADOS. That's what we're using to help us make a differential diagnosis. And if we have a tool that's not perfect, right? So the ADOS is about 80% as well, sensitivity and specificity. We're using our device to then compare to that tool that's not also perfect. So we can't reach perfection because we don't have tools that are also perfect. But what we're saying here is that the EarliPoint device is working similarly in terms of its accuracy at differentiating autism from not autism at this same rates as our other diagnostic tools that we have. The other thing it does, as you saw in the video, is it helps us quantify levels of social disability, verbal ability, and nonverbal ability. The social disability index is correlated with the ADOS. So how a child scores on this is equivalent to how they might look if we gave an ADOS. And so we're thinking about this 10 or so minutes can compare to something that might take us 45 or so minutes to do. It also provides us with information about a child's verbal ability And what this is doing is it's trying to say by what the child is attending to will give us information on how strong their language is. It's not saying how many words does a child have, but what they attend to will give us insight into their verbal abilities as well as their nonverbal abilities. And it does that. So say if I point and the child is following that point, they're knowing that that point is meaningful, and that might correlate to something language-wise. If the child is playing with a toy and they're seeing how it works, that might correlate more to a cause and effect, which might be more nonverbal ability. So how they attend and how they seem to be following what's going on in these video scenes will give us information on their kind of precognitive or nonverbal learning abilities, as well as those verbal abilities, in addition to their social disability. Okay. And each video frame is kind of pulling for one of those indices as well as this diagnostic differentiator. And so when you do the assessment, at the end, you get a report. And that report is extremely valuable because it's what you can walk through with a family when you're doing your feedback session. And so this is a couple pages of this report that's giving you some information there. And so what it's telling you is this diagnostic differentiator, right? Is this child's performance consistent with autism or is it not? It's giving you a score. That diagnostic index score has a range that's different from our standard cognitive or tools, but it's a range from -30 to +30. So children whose scores kind of are more towards the lower end of the positive or towards the negative end of the scale are going to be more consistent with a diagnosis of autism. It's going to give us, based on your clinic's prevalence rates, the chance that that child has autism given that score, what that likelihood is. So in this child's case, that child would have a likelihood of autism of greater than 99%, so very likely autism. And then it also gives us those scales. So that social disability index there, you can see the slider bars. The more purple it is the more social symptomatology a child might have. It gives us verbal and nonverbal ability scores as well. And what you can see on those slider bars is the range that it can give you. So this tool was validated, as the video said, for kids between 16 and 30 months. But we know that kids between 16 and 30 months might not be giving us verbal or nonverbal abilities within that 16 to 30 month range. And so the tool has the ability to assess verbal abilities from almost zero, almost about birth, all the way up through about 42 months of age. So if a child has a lot of delays or they have a lot of really exceptional skills, we're going to be able to see that on the scale for both those verbal and nonverbal ability. So this child, for example, their verbal ability was 6 months when their actual age was 27 months, and their nonverbal abilities fell at about 14 months of age with their actual age of 27 months. So this report would say that this child has scores that are consistent with autism. They're showing a high level, a high concern for social disability. So their ADOS score, if you know that measure, came out as a 21. The ADOS has a range from 0 to 28, with higher scores being more indicative of autism. Their verbal ability was significantly delayed compared to their age. They were achieving at about a 6-month level. And their nonverbal ability, though delayed, was a relative strength compared to their other skills. So that's how we can talk about things with families when we see what these indices show. The next page, so the right-hand kind of column, is showing just more detail. So as a clinician, depends on how much detail you like. I tend to like to dive into all the nitty-gritty details. But what this child is showing is their scores there. The gray bar that's around that line, if you can see it, the purple slope line, is also showing a confidence interval. So we can see kind of, given the scores and where that child's falling, what the confidence interval might be like. So in that child on the right-hand side, their score with an ADOS score of 21 equivalents, the confidence interval surrounding that would be about 19 to 23. So we can see what that range might be like if you were to do an ADOS on your own, for example. And then the bottom one is just showing you the Mullen verbal age equivalent in the same way, where his was falling at that 6-month time frame, and what that confidence interval around that was like would be about 5 to 7 months. Okay, so we're getting a lot of rich information from the report that it's given, not just does this device detect autism or not, we're getting all this other level of detail as well, which for me is what's really relevant for thinking about the child's unique individual presentation. We know that autism is a highly heterogeneous condition, And so this gives me information. If I saw a profile like this, I'd be like, this child probably needs really pretty intensive services, right? We've got a high level of social symptomatology, and their verbal abilities are really very, very delayed. We're probably having a non-speaking child at this moment. So let's give this child the best chance we can at success and get them into early intervention as quickly as possible. If this child were to wait in our current pathway to like over 4 years of age to finally receive an evaluation, that gap would be even larger, likely, right? And so we'd really need even more intensive services, and the likelihood of them developing language starts to go down as the brain plasticity starts to decrease. And so just thinking about using it in real world use, we're using it every day here at the Marcus Autism Center. It's really transformed our practice at this point. We're using it both in a psychology model as well as in a medical model. Slight differences. We just don't have enough psychologists essentially to meet the need of all these 16 to 30-month-olds that are coming through our door. And so essentially the way it's working for us and how we've seen it working in a lot of different centers is that the child comes in for their evaluation and a tech picks them up from the waiting room and they run this session. It takes about 10 to 20 minutes or so for them to run through the whole session from sitting them in the seat to calibrating to watching that video. The child then is brought back to the waiting room. By the time they usually take a bathroom break and the clinician picks them up, the report is generated and that information is provided to the clinician. And the clinician is reviewing that information to see, is it kind of consistent with what they were already thinking based on some developmental history they might have gotten from the child. If it's consistent, they might go in, talk to the family, maybe do a bit of play on their own just to double check some symptomatology and feel comfortable with, and go straight into a feedback with the family. And in the feedback, they'll be reviewing the report. And so they're putting that together with the parent information, right? Because we need to have, a parent expression of some of the DSM-5 symptomatology that we might not see from the report, but we get that from the parents and maybe the brief views that we have with the child. And then we provide this feedback in the console for them. The one thing that has been invaluable to me, so the page I'm showing you now is actually the last page of the EarliPoint report. And what this page is, it comes out with every report that we run on a child. And each of those pictures that are chosen is based on what the child's most representative looking patterns have been over the course. It's like the videos that are really showing where and why some of the scores were derived. And so in this child's case, we can see the two pictures that were chosen. One is the child blowing bubbles and another is a child with a crying facial expression. The next two frames are showing what the normative data sample attended to, and so what that looked like in a non-autism group of kids. And so in the top picture, for example, we can see that the kids were looking at the faces and the facial expressions of the kids as they're blowing the bubble. And in the bottom one, everyone's really driving their attention to that child's crying face. And then what it does is it shows you what their individual child attended to while they were watching those video scenes. Okay, so in this top example, while all the other kids are really paying attention to those two kids going back and forth in that game of bubbles, their child instead might have been looking at the picture frame or the lines or the bubble gun rather than kind of the facial expressions and the engagement between the two kids. In the bottom one, instead of the child looking at the facial expression, they're paying attention maybe to the cup that's in the child's hand or the toy that's on the ground. And so again, there's nothing wrong with what the child is attending to. They're certainly paying attention to stuff that's going on in their world, but what they're attending to is different than what other kids their age are paying attention to. And when they're paying attention to those things that are different, they're learning about their world in a different way. Again, nothing wrong with it. But what that's leading to is just differences in their development over time because they're not attending to those same things. And so a lot of the times when I've done my histories with families, right, what the parents are telling me is they're not attending to this world. They're not attending to what I want them to attend. They seem to be in their own world, all that kind of stuff. And what this helps parents do is really see that their child is attending to the world, but what's driving their attention is different. And so what intervention can then do is help us move that child's attention at least some of the time, right? We want everybody to gain as much as they can from their environments, but also teach them what the relevance is of what's going on these kids' faces in this children's social interaction, and to understanding why that child might be upset. And so it can help drive intervention in that way. And so for me, when I've used this, parents have really had these aha moments of being like, oh, I get it. I get that my child really is engaged in their world, but just what they're engaged with is different than what I might be looking at, or what other kids their age might be looking at. And so I thought this was really a gimmicky kind of feature from Early Tech in the beginning. But as I've used it with parents, it's been the one driver I think that really helps them understand their child and what autism might mean, and what autism might mean for their child. And also it's like, okay, now I can use something like this to say, I want to be invested in early intervention because I want to start to see that change. And so one of the things Early Tech is also doing is continued studies to be able to measure this change over time. And so if a child's engaged in intervention, now 6 months later, what does their eye tracking patterns look like? Are they now looking at things differently than they were the first time that they had this evaluation? And so I found this, again, just an extremely valuable insight really into a child's world. So giving us that window into how a child is viewing their world. Let's see. And so I kind of said a lot of this, but these indices really help us with these treatment decisions. So if a child, for example, had a pretty high social disability index, I might be thinking more about pretty autism-specific interventions, maybe caregiver-mediated interventions, maybe a high intensity of support. If their social disability index was high and their verbal and nonverbal indices were also low, I'm going to be thinking about increased intensity of services. If they had maybe lower levels of social disability and pretty age-appropriate verbal and nonverbal, I might be focusing on a different recommendation. I'm going to be thinking about what can they get from more integrated classroom type settings, right? Making sure that somebody's aware that they might have a propensity to view the world in a different way. So how can we make sure we're bringing them into environments all the time? If a child had pretty low verbal ability index, but pretty okay nonverbal ability, I'm going to be really thinking about making sure we're increasing the amount of speech therapy they get. Maybe we're going to look into their readiness for more assisted or augmented therapy communication devices. If their nonverbal indices were high or low, I should say, so they're having cognitive or problem-solving challenges, I might be thinking about cognitive stimulation. I might be really trying to promote play therapies. It might lead to some, if we're seeing a lot of sensory stuff, maybe we're going to talk about occupational therapy. So somehow the balances of what their scores mean can really drive me to making individual recommendations. And the one thing I want to say is that we have our diagnostic evaluations, and I'm a psychologist. I love doing assessment. I love seeing individual differences in children. But I am missing all those kids that are still waiting, which is delaying access to care for a huge group of children. And so though I would love to do a lot of these things, I think there's points along a child's journey where we might do more assessment, or we might do less. And if I'm a barrier to access to care, I want to do whatever I can to minimize the barriers that I'm facing or I'm placing on a child. And so if I do an EarliPoint assessment and they're not getting the same kind of comprehensive in-depth assessment that they might get if they went somewhere else that wasn't doing EarliPoint, what ends up happening is that a child goes from me and then they go to a birth to 3 system or a school system, and that system is doing their own evaluation as well. And so we also have a system, at least in the United States right now, where a child might get assessed 3 or 4 times before they actually even start services. So again, let's just make whatever ones we can as short as possible so that we can start that path as early as possible. And so with that, that's kind of the overview that I had for EarliPoint, and hopefully hit home the importance of this early identification, this increased complexity of systems that we've created by increasing barriers to care, and hopefully illustrated a solution we can have along that pathway for the family to decrease some of those barriers. So I'd love to open up for some questions if anybody has any, and see what we can do to answer them.
We do indeed have some questions. We have a very engaged bunch, and Dr. Klaiman, thank you for all that information. I know I found it fascinating. So I'm sure our audience, many of whom I think are experts in the field themselves, did as well. I think I want to start with the payer piece because we have a few questions related to that, the payer piece. And we'll start with this one, and then we have a good follow-up question. Are payers providing authorization for ABA services after EarliPoint evaluations?
Yeah, that's a really great question. We've been doing EarliPoint here, and we've done, one of the Jonathans can probably answer me better, but we've done over 1,000 evaluations here, and there's been many, many more across the United States. And as of this point, we haven't seen any problems in using a tool such as this for a child to be able to access care, whether it's ABA or otherwise. So providers are taking or insurance providers are taking our diagnosis and allowing that access to ABA services.
And then I want to follow up with this question, which came fairly early on in the discussion. Are there any specific payer policies or regulatory guidelines that you're aware of, state or federal, that either incentivize or restrict ABA providers from offering their own diagnostic evaluations in-house? This person added, I'm curious to know how these frameworks impact clinical decisions or business models. So a big question for you.
That's a huge question. And I'm not sure I'm the best expert to answer those questions. The things that I do know, though, is that the limitations systemically that seem to be put on is that the diagnosis should be made by an MD or a PhD. And when we have those, they're not necessarily guiding the tools we use to make that. And so I just say, like, if the expertise is important, I want to know that I'm talking to a family and I can explain autism to a family as well as I possibly can, so it doesn't lead to more confusion. But the tools I use to get to my answer are not what's driving success in any of those things. Yeah, but in terms of all the state rules and the government rules and the regulations, I'm not as aware of all of that, just that we're not having challenges in this being a tool being used to access care.
This is shifting gears a little bit. We have a member of the audience who's wondering, and you spoke to this, does the specificity and sensitivity change as the subject ages?
Oh, that's a good question. So within that 16 to 30 month benchmark, my understanding is no, it doesn't. There might be some, like a point here or there, but not anything globally that's going to change our sensitivity. We feel very confident in using our tool between 16 and 30 months. And now there's a study underway or just wrapped up, and we're analyzing all of it to extend the age range of EarliPoint up through 8 years of age. And we won't put out a tool that doesn't have that same level of diagnostic differentiation, right? We want it to be seen as a tool that's as accurate as what we have out there. When we use our other tools, there are differences based not only on age, but on the child's language level. And if we think about that from a clinical perspective, right, when I'm trying to differentiate autism in an 8-year-old that also has intellectual disability, that's a harder diagnosis to make, and I've got to rely on a lot of other things. Our tool is not going to have the same, it's going to be measuring the same thing in the same kid over time, right, or in the same way over time. And so it's still only going to be as good as what our comparators are out there, but it's not going to have that same, that I can tell, a variability to it.
Got it. The questions keep coming in fast and furious, and we have about 10 minutes left. So we're going to do our best to get through as many more as we can in the next 10 minutes. But briefly, I wanted to pause to say thank you to everybody who tuned in. And if you haven't already, we do want your feedback on the survey. You could see our survey located at the top of your screens. If you could take a minute or two to fill that out, we would greatly appreciate your input. We're always looking for ways to improve our webinar offerings, to figure out what topics that you want to hear most about next. But going back to the questions, we have another one that just came in from the audience. This person is asking, what happens when children will not sit for the video? And secondly, does the eye tracking differentiate between those with possible ASD and those with possible ADHD?
Sure, so that's a great question. So the first one, when a child doesn't sit. So first of all, it doesn't happen very often. We had about 3 or 4% failure rate. We could try it again. And so sometimes maybe when families come from a long way away and the child sat in the car seat, they don't want to sit more, they don't want to attend more. And so maybe doing something else to get them their wiggles out is helpful. And we have success when we try it again. We also, even though it says we need about 10 minutes of data gathering, really we only need a couple minutes to have enough of a sample, and the report won't be generated unless the data is good enough quality. So even if we can only get a couple minutes, usually over the course of watching some videos, it's usually good enough to at least get a sense of the child's strengths and vulnerabilities. I like to say that there's a lot of times where it's really hard to behaviorally test a child too, right? To try and get through some of the developmental tests that I do or the ADOS that I do. I might be under a table, I might be standing on my head, I might be, making a lot of different modifications to it. So a lot of the times it's the same kids that are showing a lot of behavioral challenges. So getting a couple minutes of the video can be easier than trying to go through still a whole battery. And every once in a while, like, we might try everything we can and it still might not work, but it's really, really very rare given the amount of time watching that's needed to generate enough data to generate a report. The second question now I blanked on. What was the second part of that question, Bob?
Differentiating between ASD and ADHD.
Yeah, that's another great question. This tool right now is validated for use in 16 to 30-month-olds. So ADHD is not quite the question then. We're obviously doing a lot of behavioral observations to try and see if ADHD is something that the family should be kind of on the lookout in the future. But at this age, kind of the differentials that we're making are between autism, maybe a global developmental delay, a language delay, a motor delay, and those kinds of things, because ADHD becomes a little bit more relevant as they get a little bit older than that 16 to 30-month time frame. And I like to say it does give us a lot of really valuable information. So if we think about those indices, the social disability index might be low, so not showing a lot of signs for autism, but maybe we have a verbal indice that's very low. And so that might give us information about a language delay. Or if both verbal and cognitive are low, that's going to give us more information about more of a global developmental delay. So even though it's not giving us an indication of at the top, like this child is not consistent with autism, but consistent with developmental delay, if you interpret those indices, it can give you a lot more information to guide your differential diagnosis.
Got it. Thank you. And I just want to let all of our attendees know, because we have a lot of questions that have come in. If we didn't get to your questions, I'm getting messages from the Early Tech team that they just want to let you all know they're committed to getting you answers. So we're gonna collect all the questions that we have, and even if you're watching this on demand, we'll see your questions as well. And the Early Tech team will do their best to get back to you with an answer. I think we're going to try to share some direct contact information as well. Another question from the audience, Dr. Klaiman. Is the EarliPoint the only assessment you include in your diagnostic reports, or do you also include a caregiver interview, an ADIR, or any other indirect assessments?
Sure. I can tell you what our battery is, and some of this is driven by our state, right? So you might have different rules in the state that you're in. Our state requires us to have a caregiver administered questionnaire that's autism specific. So our battery consists of a diagnostic interview, so we can get a sense of the parent's concern, their milestones, things that the EarliPoint we might not be able to directly see, like maybe we're not going to see stereotyped or repetitive behaviors. And then we administer, or they complete for us an MCHAT. As they get older, they might do a social communication questionnaire or the autism symptom inventory or something like that. And that's what we put into our report. Our clinicians also like to do a play session so they feel like they can show families. So we do about a 15-minute play session so that we can demonstrate to families, for example, like when I call your child's name, is this how they typically respond? So we can say, and then when we're doing feedback, EarliPoint as well as our observations were consistent with a diagnosis or not of autism. But that's sites are doing it all differently. Some are not doing that little play session. Some are more relying straight on EarliPoint in their interview, but it's also state to state specific.
What type of education do you need to use the system?
Sure. So to actually use the system, it's about an hour training that Early Tech provides. It's really easy. If you know how to use a computer and, type some information into a patient portal type thing, you can use the system. It's really an easy system to use. Having some training on child behavior management helps with the success of getting a child to sit through enough of a session. If they're one of those wiggly kind of kids or having a tantrum or something, how can we motivate them so that child behavior kind of expertise can come in really helpful for success of getting through sessions. But then other than that, it's the clinician that's going to read and interpret the report. And so we have our medical assistants that run the sessions, and then they provide the clinician with the report that comes out of it, and the clinician does the interpretation. So I like to say the clinician should have a lot of experience and expertise in understanding autism and being able to provide feedback to families and knowing what recommendations to make. But the person operating that device doesn't really need very much at all.
We have about 2 minutes left, so I'm going to try to squeeze in maybe just one or two more, depending on the length of the answer here. This individual in the audience is asking, can EarliPoint be used virtually? That's part one. And because girls and boys tend to present differently, do you see differences in gaze, or are there different videos for different genders, girls and boys having different interests?
Great question. So virtually, theoretically, yes, and EarliPoint, early tech guys, you can also jump in. Really, we are running the EarliPoint device from a separate computer. So technically, if I had a device in an offsite clinic, I could be running it from here if I wanted to. We haven't really set it up that way necessarily. People are having it at their sites. But yes, theoretically, it's being run through a different computer as long as that actual computer that's running those videos is on site where the child is watching it. And as it's run, you can pull the data up from a portal, which is also can be accessed from anywhere. So say I had a device at an offsite clinic, I could look it all up and get all the stuff that I needed remotely. In terms of different videos and gender differences and stuff, no, right now it's running the same video set for every kid. One of the things that you should know is that almost all of our early historical data was done on an enriched sample known as a baby sibling sample. So given the increased likelihood, the familial likelihood of autism in siblings, that's how our studies have been run so that we can essentially recruit fewer kids to enrich our sample with kids with autism. And when we have that, the differential gender rates are not as big as they are from a community referred sample. Pediatricians see more concerns potentially in boys that can then refer. But in a baby sibling sample, we have a much more even rate of males to females, and we weren't finding differences in males to females in this study. So I think we're going to see a little bit of a shift with using these more objective tools at younger ages, even across gender differences and sex differences.
All right, well, I think that brings us to time. A huge thank you to you, Dr. Klaiman, and thank you again to our sponsor, Early Tech Diagnostics, and to each of you for attending the session. I moderate a lot of webinars, and these are some of the most engaged questions and in the weeds questions that I have seen in quite some time, which always makes these conversations a little bit more fun. So a final thank you, Dr. Klaiman. I hope you have a great rest of your week, and thank you, everybody who tuned in. We'll see you in the future.
Thank you guys so much for having me. It's been a pleasure.